Assalamu alaikum. I am Dr. Aamir here from WIC Cardiology, and I am going to present complex PCI to RCA. 55-year male, chronic smoker for last 20 year, complaining of postprandial angina for last 5 to 6 months, which creatinine last 2 to 3. EC was normal and echo done, EF 60%, and there was no significant segmental or mission analysis. Angiography was done and it revealed. These are the views from the left system. LD is normal, circumflex is moderate proximal disease, and here is the RCA. Total RCA, and you can see from the clips from the left system, it's being filled from the collateral from the left system. So, for the JCT score for this patient was the proximal cap was ambiguous, tripled, long CTO segment, bending, it was roughly 2 to 3. And it was moderately high risk case for the CTO case, as per JCT score. How to proceed? I think there are fellows sitting here. Which guider we should take in this case, if anyone from the fellows can comment on this? Nobody? Okay. And which guide? And is there need of any supporting catheter? As per my choice, I took the AL guider for this case and I started with the pallet 50 wire. But I was unable to cross the proximal cap with pallet 50 wire. My wire was going into the side branch. So at this point, I changed my strategy. I move on to take the macro catheter along with, I kept this pallet 50 wire in the side branch as a parallel technique. I took the macro catheter and I took the higher wire, that was Gaia second wire. With the help of Gaia second wire, I was able to cross the proximal coil. But to check whether I was in the true lemon or not, I took another SS. I engaged the left system and with contralateral injection, initially I was in the subinterval course in the first clip on the left side. So I pulled away the wire and then rewire it into the distal RCA. With the help of the contralateral injection from the left system, I was able to put my wire in the right position. After all this, I changed my second Gaia second wire with the workhorse by BMW wire, and also I removed the macro catheter with the balloon tapping technique. After this, the whole disease segment was pre-dilated with 2 into 15 semi-compliant balloon. Sorry, videos are not running in this. So yes, these are the clips from the pre-dilation with 215 semi-compliant Everest balloon. After pre-dilation, the disease segment was stented. The distal RCA was stented with 3 into 38 des. The mid part was stented with 3 into 34, and the proximal RCA was stented with 3.524. R was the promus premium stent. After the stenting, the mid and distal RCA stents were post-dilated with 3.5 into 15 NC balloons at 16 ATM, where the stent in the proximal RCA was post-dilated with 4 into 15 NC balloon at 16 ATM. And after post-dilatation, this is the final view, and here you can check it. This was the procedure, the RCA which we started, and this is the, end result. Vessel fully opened and patent, there was
very nice.
Stent fully post-dilated. And the fun learning points for the fellows, macro catheter, it's very useful thing to be used in cath lab. It increases the well support in complex CTO cases, especially in the integrated approach. It also enhances the guide work tip manipulations and help in assessing side branch in complex cases. Dual injection should be mandatory in performing the CTO PCI, especially in the cases where contralateral exists. And also the parallel weld techniques, it has been established one of the most helpful technique for the CTO in the anti-grade techniques. There are some algorithm for the fellows, how to choose the wire for anti-grade desiccations. As per this algorithm, we should use filter XT or pilot 50 wires. I used a pilot 50 wire. The next wire was gas second, as in this algorithm, and then this is the hybrid CTO crossing algorithm in the cases where retrograde, where we have to plan whether we have to go for antigrade or retrograde. First, the dual injection. Second, if it depends upon the missing segments, tortuosity, calcification, and collaterals, and how is the distal vessel behaving, how is the size of the distal vessels. All these technique depends upon all these factors. If lesion length is less than 20, the good approach is for antigrade. If it is more than 20, it's a retrograde. But in our setup, we usually do with the antigrade. We are not performing the retrograde PCIs in our setups. And this is from my side. Thank you very much for the listening.